So thank you for joining us for the vein screening seminar. So typically we do these seminars live and in person, but of course with COVID, we are limited by number of people in a room and so on. So we thought that we could get this together and get it online, both for present and future use. So we're talking about vein screening, and one of the first things that people think about when thinking about venous work is they think cosmetic. But in reality, it is anything but just cosmetic. And what we're going to do today is talk about venous disease, causes, symptoms, and treatments. So venous disease is very prevalent. Approximately 45 million Americans have venous disease, and that accounts for about 1 in 4 women, or 25% of women, or 1 in 6 men, about 15% of men, will have venous reflux disease. Of course, not all of people that have venous reflux have symptoms or even need treatment, but it is something to think about in terms of what can be the long-term effects of venous reflux. Less than 4% of those who have venous disease have ever been treated for their disease. And venous disease is actually 5 times more prevalent than arterial disease to the lower extremities. And the things that we want to prevent is, if left untreated, venous disease can lead to an increased risk of blood clots, skin color changes to your lower extremities, swelling, or even in long-term effects, ulcers that can sometimes take weeks or months to heal. So this is a slide that talks about venous disease, and you can see on these 5 slides just a wide variety of the way that these can present. Up in the top left-hand corner, telangiectasias or spider reticular veins, varicose veins underneath that, the big ropey veins that are underneath the skin. And as that gets worse, you can develop things like skin changes or lipodermatosclerosis, superficial phlebitis, which is actually a blood clot in the superficial vein, not in the deep vein, or venous ulcerations, which again can take weeks or months to heal. Some of the symptoms that are associated with venous reflux disease include aching, fatigue or heaviness in the legs, pain, throbbing, burning or stabbing is very typical, cramping, swelling, especially worse at the end of the day, itching, and even restlessness and numbness. Now, of course, these are a fairly broad range of symptoms, and they can be seen in other causes such as congestive heart failure, diabetes, peripheral neuropathy, those types of things. So part of the function of the Vein Center is to try and exclude those other causes sometimes from leg pain and swelling. So what are the causes of venous reflux disease? If both family members, both parents have had venous reflux disease, you have an 89% chance of having venous disease. So very prevalent in terms of heredity. Also age, unfortunately, venous disease increases with age in terms of the percentiles. And gender, women unfortunately are 3 times more likely than men to develop venous reflux disease. Part of that is due to hormones, but part of it is also due to pregnancy. And so, for example, women who have had 3 or more pregnancies are much more likely to have venous reflux disease because of the uterus compressing on the larger internal veins in the abdomen. Obesity, we are learning that there is a slight increased risk with obesity, and so this is something that we do look at. Trauma, so if there's a history of a blood clot, that can lead to increased risk of venous reflux disease. And standing or even sitting professions. So people who do a lot of standing, teachers, nurses, factory workers, or people who are at a desk job, those can aggravate venous problems. And we'll go into the pathophysiology of why that happens in terms of the valves and long-term pressure on the valves in a couple slides that'll show that. So let's talk about anatomy. The anatomy of the veins is really broken up into 2 main parts, and that's the deep veins and the superficial veins. The deep veins, think of that as the highway going to the heart. That's a straight line from the deep system to the heart. Think of that also as maybe your interstate. That's your I-40. 80–90% of the blood flow is going up to the heart via the deep veins. And therefore, if there's a blood clot in the deep veins, that's a high risk for going to the heart and then the lungs, causing a DVT. The superficial veins is kind of your byways. Those are your rural roads, those are the connecting routes. Those superficial veins really are draining the skin, the adipose tissue, the fat. Those are all joining together, getting into the deep veins. So about 10 to 15% of the blood flow is going through the superficial veins. And that's a very rich network of veins there. And the perforating veins sometimes are these communications that can happen directly between the two. So we have here an image of the greater saphenous vein. And as the name implies, this is the longest vein in your body. It starts at the inner ankle of the leg and runs up the inner leg all the way up to the groin, and then dives deep to join the femoral vein in the groin. So it's a very, very long superficial vein. It's deep to the skin, it's in the fascia and in the muscle, but it's a very, very long vein with multiple valves that go up in sequence. That is also one of the most common veins to be treated for venous reflux disease because of its size. The small saphenous vein runs on the back side of the leg. It starts at the lateral or outside ankle and runs behind the calf and empties into the deep vein behind the calf. And it's the second most common vein to be treated for venous reflux disease. So in terms of circulation, you know, the word circulation really to complete a circuit or a revolution, circulation starts at the heart and allows blood flow to get down to the feet. It's a pretty easy system for a couple reasons. First of all, your heart is constantly beating, whether you're awake or asleep, hopefully, 60, 70, 80 times a minute, continuously. You have a blood pressure, 120/70, and you have gravity pulling that blood flow down. So the arteries getting the blood flow down typically are not the problem. The problem is the opposite, getting the blood flow back up. So think of the salmon swimming upstream. It's got to go up against gravity. And there's no central pump in your toes pushing the blood flow up. So the way that this works is this is really a musculovenous contraction, meaning anytime that the muscles contract in the legs, they compress these very superficial, these very thin-walled veins. By compressing the veins, it opens up a series of one-way valves, allowing blood flow to go up, but when gravity tries to bring the blood flow down, the valve should shut. And so this is a main reason why patients who spend a lot of time during their profession, either standing or sitting for hours and hours at a time, those valves are under constant pressure for 8, 10, 12 hours a day. Those valves can stop working and you get poor circulation, meaning the arteries are filling the veins, the arteries are filling the legs, but the veins are not efficiently getting the blood flow back up. So you get this pump mechanism going down without emptying, and you get more swelling, heaviness, and aching over time. So this is the musculovenous pump, and this is a image of contraction, allowing the blood flow to go upwards, and then on relaxation, the valves shut to prevent blood flow from going backwards. And so you can see nice upward flow on contraction, but the valves function to prevent the backward flow. So this is a normal functioning vein. And so again, we're looking at the valves functioning normally versus reflux or reverse flow in the veins, and that is shown here in this depicted cartoon here. You've got contraction allowing blood flow to go up, but on relaxation the valves don't meet and you have blood flow going down. So again, the arteries fill the legs, but the veins are not efficiently emptying the legs, leading to swelling, aching, heaviness, fatigue, varicosities, skin changes, and so on. So venous malfunction can be broken up into reflux, which we've talked about, as well as obstruction, which is a blood clot. And we also briefly touched about obstruction, and this is something that we have to rule out in terms of the causes of swelling. And so we want to make sure that during the workup we can exclude a blockage, blood clot, or any other type of obstruction as well. So next we're going to go into to treatment, and we're going to talk about both conservative and minimally invasive procedures, and I'm going to have my partner, Dr. Rudd, talk about this. Thank you.
So Dr. Mina had talked to us about the pathophysiology of venous disease, and now we're going to go into some treatment options that we have for you. And so we like to kind of break these down into conservative therapies and then minimally invasive procedures. And so we'll start with some of the conservative therapies that we have. The mainstay for conservative therapy for venous reflux is compression stockings. Basically what this is, it provides high pressure compression starting highest at the ankle and then working our way up towards the knee or towards the thigh. And the idea behind this is, again, the problem with venous reflux is that those valves aren't meeting and allowing that blood flow to pool in the lower extremity. And so those compression stockings give compression to those veins to hold those valves closer together, and they reduce the reflux of that blood. Unfortunately, though, this does not cure the venous disease. This only can help alleviate some of the symptoms. But typically, we do recommend approximately 3 months of compression therapy once we've diagnosed a patient with reflux. Other things, again, so we hope that the compression stockings are going to help with some of those symptoms that Dr. Mina had described, some of the aching, the pain, the fatigue. They can certainly also help those patients that have ulcer disease. They can help reduce the recurrence of those ulcers and speed up the treatment for patients with some of the deep vein thrombosis, those DVTs, and some of that superficial thrombophlebitis. We typically say that wearing these stockings for at least 30 minutes each day is most helpful, but the more often you can wear them during the day, the better. And then again, other things like lower extremity exercise. So getting out and walking, doing some exercise bike, things like that can certainly help, again, with that musculovenous pump to help compress that blood back towards the heart. So our next slide shows that we are now going to be talking about some minimally invasive procedures, and we'll get into a little bit more details about that. The other thing that we probably should have on this slide is a number 3, and that's more of our more maximally invasive procedures, or kind of what we used to do. And I like to describe that first before we talk about some of the treatments that we do today, just so you can have a comparison. The mainstay used to be for surgical treatment of venous disease was vein stripping. And that was a procedure that we did in the operating room that required a general anesthetic to put patients completely to sleep. It required a big incision in the groin and a counter incision down on the calf. And we literally went in and pulled that vein out of patients' legs. It was a very painful procedure, required 2 to 3 day stay in the hospital, lots of pain, lots of bruising, lots of swelling afterwards. And we really, because that was such an invasive procedure, we really only reserved that for the worst of the worst patients. Nowadays, fortunately, we have much better procedures, and so we'll talk about some of those minimally invasive procedures. And the mainstay that we do now here in the Vein Center is what we call an endovenous thermal ablation. And essentially what that means is that we actually get access to the vein, so this treatment is actually inside the vein itself, and we insert a small catheter that has a heating element on the end of it that actually causes a thermal ablation or scarring down of that vein. And so this is actually a procedure that we do in an outpatient setting, so it's here in the Vein Center. It only requires a local anesthetic, so we don't need to be in the operating room. We don't need to have a general anesthetic where you're completely asleep. And the procedure typically takes 45 minutes to an hour at the most. These thermal ablations require no long-term recovery, so it is kind of a walk-in and walk-out procedure. Patients typically have a small bit of discomfort the day of the procedure, and then afterwards are kind of back doing their regular activity. When we talk about success rates for this, what we mean is that what we're trying to do is get in that vein and completely scar that vein down, completely close it so there's no more blood flow in there. So it's as if we've pulled the vein out of your leg with that vein stripping procedure, but we've done it all through our small incision in our catheter inside the vein. And success rates for that of closing that vein down and preventing any more reflux is 99% success rate. Anytime we do any kind of procedure, we do also have to talk about complications. Unfortunately, the complication rates for these venous ablations are very, very low, less than 1%. We can also talk about some of our post-operative care. Typically after the procedure, again, you go home the same day, but we do ask that patients wear their compression stockings for approximately 2 weeks after the procedure to allow that vein to completely scar down after we've heated up on the inside of it. We do ask that patients walk as much as possible the day of the procedure. to help the blood flow in the deep system continue to flow back towards the heart. Typically, we say that patients are okay to shower the day after the procedure, and then we ask that you not be underwater, a pool, or a bathtub for 2 weeks. We usually say that we wait at least a week before we do any kind of high impact or strenuous exercise or activity. And typically we say that, again, we want you to do some light activity. The strenuous activity we ask that you hold off for at least 7 days. We ask that patients stay hydrated with drinking plenty of water the day of the procedure and for a couple days afterwards. And then typically we do a follow-up ultrasound at about 48 hours to check for any potential complications. And so typically the things that we mention when we talk about postoperative complications or adverse events would be things like bruising, some mild swelling. Usually those are pretty minimal, and patients tolerate that quite well. The biggest thing that we always mention is potential cause for a deep vein thrombosis. That is fortunately less than 1%. It's very rare, but that is why we bring patients back for that 48-hour ultrasound to check to make sure we don't have any evidence of that complication. Some other potential treatment options that we have for these patients with varicose veins, typically after we do the ablation, so after we do that endovascular thermal ablation, if patients continue to have some visible ropey varicose veins that are right underneath the skin that are still causing either some discomfort or patients don't care for the looks of those, we can go in and do what's called a microstab phlebectomy. So this is completely different from the vein stripping. This is where we make very small little 2 to 3 millimeter skin incisions along the length of that varicosity and use a little vein hook to actually pull those small varicose veins out. Again, we do this under local anesthetic. Patients tolerate this quite well, and again, it is an outpatient office setting procedure. So here are some pictures that we have of patients, some before and after pictures to kind of demonstrate some of the changes that we can see in patients after they've had ablations, and some of these patients have also had the phlebectomies as well. Again, when Dr. Mina was talking, a lot of times patients think of these as cosmetic procedures, and really, even though the pictures are quite impressive, seeing the before and after pictures, the main thing that we like to see is that patients come back in telling us that their legs not only look better, but also feel much better. A couple other things that we do here at the Vein Center are some more of our cosmetic things. The mainstay would be sclerotherapy. That would be cosmetic procedures for those very small spider and reticular veins. Unfortunately, this is a cosmetic procedure, so insurance companies do not pay for this, but sometimes after we've done the radiofrequency ablation and sometimes that microstab phlebectomy, if we still have some of these small spider and reticular veins, we can go in and inject a polydocanol sclerosing agent into those small spider veins to get those to disappear. And we usually say that patients can expect about an 80 to 90% reduction in the appearance of those small spider and reticular veins. And again, here are some before and after pictures of the sclerotherapies. You can see on the picture on the left, the patient still has several spider veins and some of those slightly larger reticular veins. And then the after picture is approximately 6 months after, so it does take a little bit of time to get those to resolve, but pretty significant before and after results on those. And so again, in conclusion, we appreciate you watching our video and letting us tell you a little bit about some of the newer options that we have for helping patients with these venous reflux and varicose vein disease. Again, much different than the way we used to treat these, and having very good results with very minimal downtime, very minimal office procedures, and patients that are very happy with the results. So thank you so much for your time.